Hello.
Yeah, can we start now?
Hello.
Hello? Can we start now?
Hello.
Hello?
Yes, sir. Can we start the class?
Yeah, sure. Okay. Good evening. My name is Dr. Shakti, and we are going to continue with our revision series for the exam. Today we're going to start off with your cardiovascular system. So under cardiovascular system, today we'll be basically dealing with your cardiac cycle, your electrophysiology of the heart, cardiac output, and a little bit about heart failure. And then tomorrow we'll go to the rest of the topics that include some clinical context, like shock, and apart from that, an important question like regulation of BPM and your regional circulation. Okay, so just take a look at some of these questions, like a long essay, discuss the regulation of cardiac function. So this looks like a vague question, the role of autonomic nervous system, endocrine influence, and starting mechanism. But essentially what they're trying to get out of you is how your cardiac output, stroke volume, heart rate, all of these are regulated. What is the influence of autonomic nervous system there? What is the influence of the endocrine system over there? So these are the things we cover under your homeometric regulation, metrometric regulation, as well as your extrinsic regulation and the involvement of Starlink mechanism. So this is basically cardiac output. Okay, a little bit of BP control also comes because the way it is written, it's a cardiac function. So a little bit of BP control also should be mentioned here. Regulation of BP, which we are not doing today. Okay. Then you can see other questions, phases of cardiac cycle, okay, including pressure and volume changes that occur in the heart. So when a question is coming like that, then you'll have to draw a diagram of pressure volume. Okay, the PV loop, you should draw it and explain it. Then explain the electrical conduction system of the heart. Sequence of events from SA node to the Purkinje fiber. Then outline the factors that influence stroke volume and heart rate. Okay, and integration into cardiac output. So this is pretty much the same thing, but since it is short essay, it will be lesser mark compared to this. So the amount that you have to write is going to be different. And then we have what is preload and how does it affect cardiac function. And then define cardiac output, the formula and how to calculate it. Then role of baroreceptors, again, we're not doing it today. We'll be doing it tomorrow. So like always, I'm going to first set up a few questions and based on that, we'll be discussing about that. Okay, because this is a revision. What is important is what we have to cover. So one group of questions explain the steps in cardiac cycle. This can come as a 3-mark question. It can even come as a 5-mark question. Write a short note on heart sound. 2-mark question. Okay, if it comes as a 3-mark question, you have to write a little more extra, that's all. Pressure volume loop in cardiac physiology. So that is what we saw over here. The pressure volume changes and cardiac cycle. Okay, so in cardiac cycle, you have to talk about it with respect to systole and diastole. In systole, you have to talk about first isovolumetric contraction. Isovolumetric contraction will be followed by a rapid ejection phase, that followed by a slow ejection phase. Okay. Diastole, usually just before diastole is the protodiastole. Then your proper isovolumetric relaxation starts. So protodiastole is a phase in between systole and diastole. Then isovolumetric relaxation happens. Then initial rapid filling, slow filling, atrial systole. This can be explained with the help of a pressure volume loop. Okay, so on one side we have the volume and on the y-axis we have the pressure. So what we're going to see here is at the end of your diastole, at this point, your mitral valves close. So the mitral valves are closed. Yes, the semilunar valves are also closed. Since both are closed, the pressure builds up inside. Okay, that is your isovolumetric contraction. So the mitral valve closes, the semilunar valves are already closed. And now that is going to start an isovolumetric contraction because the volume does not change. What will happen? The pressure increases. So this is your isovolumetric contraction. Okay, and this closure of mitral valve is your first half sign. Then an isovolumetric contraction happens. Then, because of that, the pressure increases, and ultimately at some point, the pressure inside becomes greater than the pressure outside. The lowest pressure outside is the diastolic pressure. So once it crosses that lowest pressure, which is there outside, then it opens up, resulting in ejection. Now, initially, the ejection will be a rapid ejection because the pressure difference is pretty high. From inside to outside, the pressure difference is pretty high. Okay, for that, what happens? The aortic valve opens over here, and on the other side, the pulmonary valves. And this is going to be a rapid ejection. Now, after rapid ejection, then with more equilibrization of the pressure between the inside and the outside, that point, it starts slowing down, and there'll be a slow ejection. Now, as there is a slow ejection, eventually what is going to happen? The pressure which is there on the outside, that is in the systemic circulation, will be higher than what is the pressure inside because all the volume inside the heart is going away. So because of that, at some point, there's going to be some sort of a backflow. And because of that backflow, in your pulse tracing, you see a dichrotic notch. And that will result in a closure of the aortic valve. That closure of the aortic valve is your second half sign. Okay, and this phase where the backflow is happening, that is your protodiastole phase. Okay, so we have the isovolumetric contraction, the rapid ejection, slow ejection, then protodiastole happens, followed by closure of the second, the aortic valve, that results in the second heart sound. After second heart sound, both the aortic valve and the mitral valve are shut, resulting in isovolumetric relaxation. And when there is a relaxation with a change in volume, that is going to be a drop in the pressure. The pressure will keep dropping. Okay, so once the pressure keeps dropping, at some point, the pressure in the atrial chambers will be higher because of filling. And that will result in opening of the mitral valve. So, diastole, mechanical diastole starts with isovolumetric relaxation, followed by the filling phase, where the volume in the ventricle will increase. Initially, there is going to be a slow filling. Now, there is going to be a rapid filling actually because of the pressure difference. And then that will slow down, just like here. Okay, so initially a rapid filling is there, then a slow filling will be there, and then by then 70% of the filling is done. Remaining 30% will require atrial systole. Thus, your volume inside the ventricle will shift from your end systolic volume at the end of systole, whatever volume. This was the volume at the end of systole. That volume to the volume at the end of diastole, that is end diastolic volume. And the volume difference between your end diastolic volume and the end systolic volume is the amount that is being injected each time. That is your stroke volume. Okay, so this one diagram can explain your cardiac cycle, parts of the cardiac output, stroke volume, all of these can be explained. End diastolic volume, end systolic volume, and all that. So this is very important, often asked as a question. The next question is your heart sound. When you're talking about heart sound, you have the first heart sound, the second heart sound, majorly there. First heart sound is often heard in the tricuspid area, the mitral area best. The second heart sounds are heard in the pulmonary area and the aortic area. Okay, the mitral area is where the apex beat is there. Tricuspid area is somewhere around the fourth intercostal space on the left side, left margin of sternum. On the second intercostal space on either side is your pulmonary and aortic area. Okay, the first heart sound is AV valve. Okay, the AV valve closure, if you look at it, the pressure difference between the atria and ventricle is not much. So it lasts longer. And it has lesser frequency of sound. It is soft, dull, low pitch. But semilunar valve closure, that is the difference between your pulmonary vasculature or the systemic vasculature versus the ventricle. Because of the pressure difference, it closes much more faster, 0.12 seconds. It has a frequency of 50 Hertz. So it is shorter, sharper, and high-pitched. This second heart sound can split into your pulmonary and aortic area. This is exaggerated when you take in and deep inspiration, resulting in splitting of heart sound. The second heart sound can have a splitting of the heart sound. This is because of the pressure differences between the left side and the right side. Where the pulmonary vasculature, it is 25/7 millimeter mercury. The systemic vasculature is around 120/80 millimeter mercury. And that pressure difference with respect to your ventricle. Plus, when you inspire, what is going to happen? Your pulmonary vasculature resistance is going to increase because your lungs are expanding, making it more difficult, and it will take longer time for passage into the pulmonary vasculature. So closure of this P2 is going to take longer than P2. Okay. Then, so these two are the most important things. If it is asked for 3-mark question, then you should also try writing a little bit about third heart sound, fourth heart sound, and your abnormal sounds. The third heart sound is because of the initial rapid filling. Fourth heart sound is because of the atrial systole. Abnormal sounds include murmur, bruit, and all. So bruit is a sound that you hear, like especially in the vasculature areas where turbulent flow is there, then you hear bruit. Okay. Murmurs are when there is some sort of turbulent flow, which are apart from the heart sound that you hear. Okay, so because of some abnormality where there's some stenotic valve or there is some sort of regurgitation happening, because of that, there will be some abnormal sounds that can be there. That is your murmur. Okay, next set of questions. What is pacemaker potential? Write a short note on pacemaker potential. Draw a neat label diagram of ventricle action potential and explain the various components. Then a 5-mark question of conduction system of heart. Pretty important. Okay, so these 3 questions, at least one of them will usually come. So one thing, this is your ventricle action potential. This is a pacemaker potential. Pacemaker potential is what you see in the pacemakers. Usually in the SA node, but if SA node is not there, it can also be there in the AV node. It can be fibers. Okay, so pacemaker potential has initially a calcium mediated activity, because of which it is slower. Okay, so there is a transient type of calcium channels which are activated, resulting in a slow depolarization wave. Then a long-acting calcium channels are opened up once it reaches the threshold. Then potassium efflux is again the reason for repolarization. Now, during repolarization, as it is going towards hyperpolarization, that is when a group of ion channels, HCN channels, are activated. The thing about HCN channels are they're hyperpolarization gated channels. Usually, depolarization wave opens up any of these channels. But these are hyperpolarization gated channels. Thus, during hyperpolarization, as it is moving towards hyperpolarization, they get activated, resulting in non-specific cation influx until it reaches a potential where your transient calcium channels are opened up. Okay, so that is your pacemaker potential. And this is where something called the funny current is coming. So this funny current, because normally depolarization wave activates the channel, but here instead a hyperpolarization wave activates the channel. Okay, so we have transient calcium channel, long-acting calcium channel. You have the potassium efflux over here, and this is the funny current because of HCN channel. Okay, now this is in the pacemaker. In your ventricular or atrial muscle, cardiac muscle, what is going to happen is these are the various phases that you see. The phase 0, which is very sudden spike. If you see a spike like that, that is because of sodium. So there is going to be a sodium influx, resulting in rapid depolarization. Then repolarization starts. Repolarization again is because of potassium efflux. For that, we have an initial rapid repolarization. Okay, we have a initial rapid repolarization. That is phase 1. And at this point, your potassium is going outside. If along with that, your calcium is coming inside, they're going to balance out each other, resulting in a plateau phase, that is phase 2. So phase 0 is influx of sodium, resulting in rapid depolarization. Phase 1 is potassium efflux, resulting in rapid repolarization. Phase 2 is potassium efflux plus your calcium influx. Okay, and this plateau phase is the reason why your cardiac muscle has a long refractory period. Sometimes questions like this come, like 1 mark and all, or part of essay, like what is the cause for long refractory period? That is because of the plateau phase, because of calcium. Even part of the MCQs, which ion is involved for long refractory period, like that, some sort of question if it comes, that is because of the plateau phase or the calcium influx or phase 2. Then what will happen? A rapid late repolarization will happen, that is phase 3, where calcium is no longer there, again only potassium influx. And then it goes to the baseline, phase 4, and then it goes back again. So if a question of pacemaker potential comes, or your cardiac muscle potential or ventricle action potential, these two diagrams should be drawn and you should explain it. Okay, the next question is the conduction system of the heart. When you talk about the conduction system of the heart, you have to understand conduction system are nothing but modified cardiac muscles. The cardiac muscles have been modified. Okay, they are modified in such a way that the number of gap junctions are higher and easier transport across. Muscle striations are lesser. Okay, now it starts off from the sinus node, and then we have the AV node. So we have the sinus node, AV node, and connecting them are internodal bundles. There are 3 internodal bundles normally: Bachmann, Thorel, Wenckebach. Okay, so internodal bundles like Bachmann, Thorel, Wenckebach, SA node, AV node. Now, after the AV node, there is a His bundle, which will split into left-sided and right-sided bundle, which will now go into the muscle and become Purkinje fibers. This is essentially your conductive system. Now, how does the progression occur? First, pacemaker potential happens in the sinus node because that is the fastest. If something else is the fastest, that will take over. So because sinus node is the fastest, that is where the pacemaker potential starts. And it gets carried through the internodal fibers. And during this whole process, there is depolarization of the atria. And then it reaches the AV node. Now, the SA node and the AV node, their conduction rate is less. Because of that, there is somewhat of a AV nodal delay. Around 0.1 second delay is there. And the reason for AV nodal delay is to make sure that the entire atria is depolarizing well enough in order to allow for a atrial systole so that the remaining 30% of the end diastolic volume is filled up. If that does not happen and immediately ventricle contracts, systole will happen even before adequate filling. So in order to prevent that, you have an AV nodal delay, which is beneficial for us. Now, after that, from the AV node, it is going to come down. And when it is coming down, it will first go through the septum and it will go from left to right. It will activate the septum left to right. Left to right septal activation. That is followed by its movement through the septum all the way to the apex. And then it is going to come down back and go on the underside. So sometimes the question comes, which are the last parts of your heart to be depolarized? They are this upper back part of the septum, the base of the ventricle, and finally behind the pulmonary conus. The upper part of the septum, base of the ventricle, pulmonary conus are the last parts of the heart to be depolarized. Now, as we were talking about earlier, the SA node and the AV node have lower conduction rates. The highest conduction rate is for Purkinje system. If we talk about the discharge rate, highest is for SA node. Then AV node, then Purkinje system. Okay. Next set of questions. What is bipolar versus unipolar lead? Okay. Draw the waves of ECG and explain. Uses of ECG and certain clinical things like what is the importance of PR interval, what is heart block, what is arrhythmia. So bipolar versus unipolar limb lead. May not be just limb leads, just leads. Okay, so bipolar leads, usually your lead 1, 2, 3 are bipolar leads. You give an example and explain why it is bipolar because 2 active electrodes are there. You can see here between this and this, both are active electrodes. Or at a time you take this and this. Or at a time you take this and this. Okay, so that is 2 active electrodes. When 2 electrodes are active, one will be positive, one will be negative. And between them, what is there, that is what to check. The 2 active electrodes and give the example. That is bipolar. One example of unipolar is your chest beats. So in unipolar, what do they do? You take a reference point. So you take a reference point somewhere and you take an active electrode. With respect to a reference point, which is almost near zero potential, you take this as a positive. So these leads that you put for chest leads, okay, that will be with respect to a central point in the chest around where the heart is. And that is a inactive terminal. So one inactive terminal, one active terminal. That is how you use a unipolar lead. Unipolar leads examples are your unipolar chest leads. Unipolar limb leads are also there. Like for example, your VL, VR, VF, which when augmented becomes AVL, AVR, AVL. Okay. Now the question of draw diagram of ECG, explain its parts. So we have the P wave, the QRS, T wave. Okay, so we have the P, QRS, T. P wave is because of atrial depolarization. Q is the part where we were talking about left to right septal activation. That will be followed by the ventricular activation where it goes to the apex. And then where it goes back to the base and the pulmonary corners and all that, that is where your S waves come. So that is a QRS complex. And then T wave is actually ventricular repolarization. And when atrial repolarization happens? Atrial repolarization happens somewhere during the QRS complex, and hence it is masked within it. Now, apart from that, we have these isoelectric lines in between. So by the end of P to the beginning of Q, that is your PQ segment. The end of S to the beginning of T, that is ST segment. Or there can be intervals where you include a wave along with the segment. So you take the P wave along with the PQ segment, that is called PQ interval. Sometimes it's called PR interval or PR segment when the Q wave is not visible. And ST interval will be this whole thing. And then we have RR interval between two R. Okay, or if you include Q, the beginning of Q till the end of T, that will be QT segment. So these are all different things that you need to label. And they can sometimes be a U wave because of slow repolarization of the papillary muscle. Sometimes there might be a U wave. The next question, what are the uses of the VCG? One, to count the heart rate. How do you count the heart rate in ECG? Take the RR interval basis. Okay, so in some way, what are you going to do? You count the number of small boxes or the large boxes. So you take the distance between this to this. Sometimes questions or problems might come to calculate. Okay, so you see how many large boxes are there? 1, 2, 3. And if you include this around a 4 box, so 300 by 4. Or you look at the number of small box. Okay, so again 1, 2, 3, that will be 15 plus 1, 2, 3, 4, and this one's 5. So that is again 20. So here they're both similar. Okay, so 1500 by number of small square 20 or 300 by number of large square 4. Okay. Another important question, what is the importance of PR interval? The PR interval normally has a range of 0.12 to 0.2 seconds. Okay, so this is the period where from the P wave is coming, atrial depolarization is happening. Q is when your ventricular activation is happening. The time from the SA nodal discharge till it finishes the AV nodal delay. The PR segment is where the AV nodal delay is happening. That is the importance of PR interval. The timing from the first discharge in the SA node till when ventricle is stimulated. So this is the normal range timing of it. Okay. So we have the P wave, we have the QRS complex, and this is the PR interval, PR segment. Okay. And if this is less means somehow fast conduction is happening, because we told AV nodal delay is there for a reason. If that does not happen and some reason fast conduction is happening, there might be some other aberrant pathway which is bypassing your AV nodal delay. Or if it is taking too long a time, that means some sort of conduction block is there. Okay, so based on the marking of this question, PR interval's importance, if it's just 2 marks and all, you just explain only this much. If it is like 3 or 5 mark question, then you have to explain what is the conduction block, what are the aberrant pathways, like that. So depending on the marks of the question, you have to answer this question. Okay, so again, separately, conduction block can come as a short note. Conduction block can be complete and incomplete. Incomplete conduction block can be first degree and second degree. In first degree conduction block, what is going to happen is there will be slowing of conduction. That will be seen as an increase in the PR interval. No misbeats will be there. That is first degree. In second degree, in some form, some misbeat is going to happen. So in Mobilitz type 1, what is going to happen? One, the PR interval will keep increasing. The next PR interval will be like this. Next PR interval will be like this. And then the P will be there. There will be no QRS complex. So progressive prolongation of PR interval with a misbeat. In Mobilitz type 2, there will be some ratio. 2:1 or 3:1 like that. So 2 P waves will be there. For that, 1 QRS complex will be there. That is 2:1. Or if 1, 2, 3, and 1 QRS complex. So this is 3:1. So Mobilitz also has misbeats. In complete, what is going to happen? We have many P waves which has no QRS complex. And randomly in between, you will see some QRS complex which has no relation to your P waves. And if you look at the rate, it's going to be so slow. This RR interval late, if you calculate, is going to be slow. This is called idioventricular rhythm. Okay, so a short note on conduction block is coming. Incomplete, complete, first degree, second degree, Wenke-Back phenomena, Mobilitz type 2. All of these you have to discuss. Sometimes in parts of long structured essay and all, I've seen these two, one of these being asked for 1 mark, half mark and all. So what is Stokes-Adams syndrome? What is X-Sinus syndrome? So in Stokes-Adams syndrome, one of the problem is some form because of a conduction block. Heart is not pumping enough, and that will result in some form of fainting episodes because of that. So some sort of conduction block is there. The ventricle is not contracting enough because not enough impulses are reaching. Only see here, here, here. That is the amount of ventricular contraction instead of see this much. So that will result in decreasing the cardiac output and fainting episodes. That is Stokes-Adams syndrome. In X-Sinus syndrome, what is happening is, your sinus rhythm is affected. There is some abnormality in your SA node, whereby it is not being able to discharge properly. Usually with age, some other factors, radiation therapy and all that, you usually have your destruction of your pacemaker cells, resulting in X-Sinus syndrome. Okay, so the other one is accelerated AV conduction. Example is Wolff-Parkinson-White syndrome. The one, Ganong-Levin syndrome. Okay, the only thing is in Wolff-Parkinson-White syndrome, there will be short PR interval with an abnormal QRS. In Ganong-Levin, short PR interval with normal QRS. Then a question of arrhythmias or ectopics might come. Okay, so usually when there is an ectopic, that is always followed by a compensatory pause. I've seen a question where they ask why compensatory pause is happening. So when one single P wave is there, QRS complex is there, P wave is there. Okay, then P wave is there, QRS complex, P wave is there. Now imagine over here, this is a P wave, a QRS complex here, and now what will happen? Some ectopic is coming, an ectopic period. Okay, and that ectopic resulted in some sort of a activity, because of which now earlier form is there, but that will not be coming, that will not be followed by this beat. Instead, whenever the next beat was supposed to come here, so there is a pause here. So this is because the next SA node discharges over here. And until that time, even if it came earlier, it has to wait for the next signal to reach. That is why there is always a compensating pause. If a question like that is separately coming, that is how with a diagram you can explain. Then arrhythmia can come as a question. Problems in the rhythm. So rhythm abnormalities can be atrial or ventricular. Some external source of ectopic, which is either in the atria or ventricle. And based on the rate, the naming changes. If it's just 100 to 120, 220 and all, the rate, we usually call it tachycardia, atrial tachycardia, ventricular tachycardia. But if it goes beyond that, it becomes 200 to 350, we call it a flutter. 300 to 500 rate, fibrillation. So 100 to 220 is tachycardia, 200 to 350 is flutter, 300 to 500 is fibrillation. So you can see here, this is atrial tachycardia. Why do we say it's atrial? Because you see P waves are the abnormal ones that keep coming up. So you see here, there is an abnormal P wave that comes up. And then there's going to be a compensatory process. But if this abnormal P wave keeps coming repeatedly at a high rate, that will result in atrial tachycardia. If it's even more faster, that is atrial flutter. And here you see fibrillatory waves. It's too fast for your normal conduction to happen. And you can see that in between some ventricular activity is there. But apart from that, it's too fast. Okay, so that is atrial fibrillation. And because of that, atrial fibrillation usually has an irregular rhythm. In ventricular arrhythmias, usually you can see here the problem will be some ventricular ectopic. So some form of abnormal, like this either will come or like this will come based on the direction. Some abnormal ventricular rhythm is coming. Okay, and that when it's very fast can be ventricular tachycardia, ventricular fibrillation, flutter, based on the rate as we are talking about. Okay, and this is how you differentiate between them. So abnormal, P wave will be there. In ventricular, the QRS will be abnormal and prolonged. And because in ventricular, usually there is no P wave will be seen. Because the starting point is the QRS complex, starts off with that. And because of the sinus rhythm on top will get masked down within it. Then another, so don't forget, here we are still in uses of VCG. Heart rate is one thing we saw. Then rhythm abnormalities to detect it. Then myocardial infarction. What we see is an ST segment elevation and ST segment depression in the opposite leads. And here you see lead 1, AVL, and V5, V6. That means it's a left-sided problem. Instead, if it was lead 2, 3, AVF, it would have been inferior wall MI. Then apart from that, ionic imbalance, especially for potassium. So in hyperkalemia, you usually see a tall peak P wave. And as the level of it increases, then you see that an abnormal QRS can be there. P wave can be absent. So initially, from the normal range, it goes to around 7 millicurie per liter till 7 millicurie per liter. It can result in tall peak P waves. Beyond that, abnormal QRS and absent P waves. In hypokalemia, what is going to happen? You usually sometimes see a U wave. ST depression can happen. Further lower hypokalemia can result in a P wave inversion and prolongation of PQ interval. Okay, so these are different things. This also can separately come as a short note. And apart from that, the other uses of ECG is for axis deviation. Usually say that from minus 30. So some textbooks say plus 90, some say plus 110, but this is the normal cardiac axis. Okay, so within that range, it is okay. And otherwise, it is left axis deviation, right axis deviation. Another group of questions, pulse wave tracing, what is blood pressure, Auricle sound. So there'll be like short note on pulse wave tracing with neat label diagram, pulse wave tracing. Note on blood pressure, Auricle sound. Okay, so pulse wave tracing includes, so this is your systole, this area is the systole, diastole, and this is the full cardiac cycle, 0.8 seconds. Out of that, 0.3 seconds is systole, 0.5 seconds is diastole. Okay, now what you have to see is there's going to be a percussion wave like this. And this dicrotic notch is the point where protodiastole is happening and backflow is happening. And once the second heart sound comes because of the closure of semilunar valve, the blood which is retreating back will bounce back, resulting in a dicrotic wave. And we have two limbs. We have the anacrotic limb and the dicrotic limb. So anacrotic limb, dicrotic limb with percussion wave, dicrotic notch, dicrotic wave. Sometimes you may see a tidal wave also. Tidal wave can be either after or before also the dicrotic notch. Blood pressure, it is a lateral pressure exerted on the vessel wall. Systolic blood pressure, the maximum pressure exerted during the cardiac cycle. Okay, normal value is also given. Diastolic is minimum pressure exerted during the cardiac cycle. Pulse pressure is the difference between systolic and diastolic pressure. Mean arterial pressure is the average pressure exerted throughout the cardiac cycle. That is given by the formula diastolic BP plus 1/3 of pulse pressure. Auricle sound, if a question is coming, you'll have to talk about the various phases. So usually phase 1 is there where you hear a tapping type of sound. Phase 2 is there where you get a murmurish quality. Some textbooks mention it as swishing sound or blowing sound. So all of it, any of it you can write. Then phase 3 where a thumping kind of sound is there. It can also be written as clear, loud sound, knocking sound, crisp sound, different responses are given for that. And phase 4 is where a muffling is there. So where you start hearing the sound is your systolic BP, and where muffling ends, that is your diastolic BP. Okay. Now, next set of questions. Define stroke volume, cardiac output, ejection fraction. What are the factors affecting cardiac output? Factors affecting venous return. Homometric versus heterometric regulation. What is Frank-Starling's law of heart? Then methods of measurement of cardiac output, and what is the difference between left-sided and right-sided heart failure? So this is essentially talking about your cardiac output. So what is stroke volume? The amount of blood pumped by each ventricle per beat or per stroke. That is stroke volume. Okay. So we have the end diastolic volume. From there, after a stroke, we have end systolic volume. So how much in between was taken out, that is your stroke volume. Okay, usually it has a range of 70 to 90 ml. And if you say how much has been ejected, the fraction of the blood that has been ejected, that is stroke volume divided by end diastolic volume. Out of the total end diastolic volume, how much of stroke volume is there? Gone. That is the fraction. Okay, so that if the ejection fraction usually comes around 65%. Then we have cardiac output. The amount of blood pumped by each ventricle, same, per minute, in a minute. So That is how you get the formula. Stroke volume into heart rate is cardiac output. The amount of blood pumped by each ventricle per beat is stroke volume. That for a minute is number of heart rates. So that's why cardiac output is stroke volume into heart rate. Okay, normal value is 5 to 6 liter per minute. In males, females 4.9 liter per minute on an average. Now, what are the factors affecting cardiac output? Again, the same formula. Okay, so we have heart rate and stroke volume. Heart rate is something that is controlled by your external innervation. Your autonomic nervous system is something that can control it. Okay, so that is part of our extrinsic regulation. Then stroke volume is there. Stroke volume is a function of your cardiac muscle. And there are two types of regulating it. One is called heterometric, other is called homometric. So in heterometric, the regulation is based on the initial length of the muscle, based on how much the length is changing. So based on the length changing, it can regulate the stroke volume. So for example, if the length is more, it will result in more force of contraction. That is heterometric regulation. Apart from that, there is a homometric. Regardless of what the initial fiber length is, the innate property of the heart to increase its contraction can be increased. That is homometric, not at all dependent on the initial length. Okay, so that is homometric and heterometric. So these we have to explain based on the number of your marking. With 3 marks or 5 marks, based on that, you have to understand how much of it to explain under this. Okay, so if your extrinsic heart rate changes, how is it regulated? You have the sympathetic, which is going to the SA node as well as the ventricles, the atria, and all that. The vagus mostly goes to the nodal fibers, does not go into the ventricle section. So, what are the factors affecting heart rate? One, psychic stimulus, excitement, anger, pain, exercise, all that increases heart rate. Fear, grief, and all that slows the heart rate. Fever said that 1 degree Fahrenheit increase will increase the heart rate by 10 beats per minute. During inspiration, the preload increases, and that will result in increase in the atrial stretch receptor activity and will increase the heart rate. The baroreceptors, all this will be talking about tomorrow in regulation of BP. Decreased activity of arterial baroreceptors is another thing that results in increase in heart rate. What slows? Again, increased activity of baroreceptors, or opposite of inspiration, expiration. Okay, or sometimes increase intracranial pressure, which is called Cushing's reaction. It's a type of CNS ischemic reflex. Okay, all of this we'll be talking about it tomorrow. So these are the things you have to talk about under. So if it's a 5-mark question of factors affecting cardiac output, you talk about extrinsic regulation, then you talk about homometric, heterometric. Under extrinsic regulation, you talk about the heart rate and talk about all of these things. Then you go to homometric and heterometric. Okay, in heterometric, you talk about preload. Based on increase in the preload, the volume increases. That means how much the stretch of the muscle is there before contraction. So, based on the initial length of the muscle fiber, until the physiological limit. As you keep increasing, at some point, it will stop falling. It will stop increasing and instead fall. So, force of contraction is directly proportional to the initial length of muscle fiber until its physiological limit. And that is what is called Frank-Starling law of heart. So, basically, what is happening when preload is increasing? End diastolic volume increases, muscle length increases. And because of that force of contraction. So if, for example, some contractions, not enough blood has gone out, stroke volume was lesser, that will increase the amount of blood which is there at the end systolic volume, which means that the next end diastolic volume will be higher. So since there is higher end diastolic volume, this contraction, what will happen? It will contract more forcefully and make up for that earlier deficiency. So this is one way by which Frank-Starling's law of heart is working. This is an example of your isometric regulation. Okay. Now, preload, one of the things that is related to preload is your venous return. Okay, venous return is not exclusively preload, but one of the things that is related to your preload is venous return. So if a question of what are the factors affecting venous return, one is how much blood volume is there. What is the vascular tone? There's something called a muscle pump. So as you stand up and stay longer and then you activate your muscles, then venous return will increase. Or there's a thoracic pump based on increased inspiration resulting in negative intrathoracic pressure, and it'll pull it up. Posture, another thing. Okay. And again, based on the cardiac pump, based on the ventricular compliance, how much of blood can actually go out per cycle, all of that will also affect how much blood is coming inside. Okay, so these are the factors that affect venous return. Apart from preload, there is also afterload. Afterload, when it increases, cardiac output decreases. That is the load against which your heart has to contract. Okay, so when there's hypertension outside, systemic vascular resistance is increasing, or something affecting the elasticity of the arterial tree, or higher number of blood volume outside. All of this can increase the ventricular afterload. Okay, so afterload decreases the cardiac output. Preload increases the cardiac output to a physiological limit. Then we have your homometric regulation, which has nothing to do with the initial length, but the innate property, inotropy. Okay, so there are certain things that affect this contractility. So for example, you give inotropic agents like digitalis, xanthin, glucagon. These will increase the contractility, and it has nothing to do with the initial length. The catecholamines which are there, the sympathetic system, all of this will result in increase in the force of contraction. On the other hand, if we give pharmacological depressants like quinidine, procainamide, barbiturate, there is some sort of loss of myocardium, hypoxia, hypercapnia, acidosis, parasympathetic activity, all of that will result in decrease in the force of contraction. So under homometric, you can talk about things that increase, that is positive inotropy, and things that decrease, that is negative inotropy. Okay, so again, these are the various things that you have to talk about. So your contractility, preload, that is your homometric, heterometric regulation affects the myocardial fiber shortening, and that will in turn control the stroke volume. Heart rate is again extrinsic regulation, and then that will decide the cardiac output. So cardiac output with peripheral resistance is what makes up your BP. If a question of factors affecting cardiac output comes, you can also, apart from those other points we were talking about earlier, homometric, heterometric, extrinsic, all those factors you can write about it. Apart from that, you can also write about these certain aspects, like exercise can increase up to 700%. Anxiety, excitement can increase up to 50 to 100%. Eating can increase up to 30%. Okay, and change in posture from sitting or standing from lying down position can result in a 20 to 30% in decrease momentarily, which will be corrected. Okay, so usually sleep, on the other hand, has no change. And if a question of what are the methods of measurement of cardiac output, you can talk about echocardiography, Doppler. In animal models, we use direct cannulation. Otherwise, it makes no sense to directly cannulate in order to get BP. In humans, indirect methods are there. It is indicator dilution and thermodilution. And we also have plethysmography. So these are the methods that you need to mention in order to answer this question of methods of measurement. Then talking about heart failure, failure of the heart to maintain an adequate cardiac output for normal perfusion. So in order to maintain adequate cardiac output for normal perfusion, if it is not able to do it, heart is not able to do, that is heart failure. It can be the diastolic type of heart failure or systolic type of heart failure. But the usual question that is asked is, what is the difference between left-sided and right-sided heart failure? So in a left-sided heart failure versus a right-sided heart failure, what is the essential difference? When the right side of the heart is affected, the problem is the right part of the heart is not contracting. So the right to the pulmonary vasculature, it is not going. The problem will be the back area. The blood that is coming to that area will be the problem. So for the right heart, if it is not able to pump enough to the pulmonary vasculature because of, pulmonary artery hypertension, something like that, the venous return will decrease. Hydrostatic pressure in the peripheral venous system increases. That will result in pedal edema, fluid retention in the body, especially pedal, and hepatomegaly. On the other hand, if it is a left-sided problem, that means the backflow, left side is not pumping enough. So the blood which is coming to the left side does not reach because it's already full. Instead, it keeps getting accumulated in the pulmonary vasculature, resulting in pulmonary edema, difficulty in breathing. So these are the differences between the left-sided heart failure and right-sided heart failure. Okay, so that is some of the important things that we can cover in 1 hour for the initial parts of the cardiovascular system. So talking about the Auricle, Auricle's got foundational classes which are there, which are pre-recorded sessions, and you can look at your own convenience. This includes practical sessions as well, which have been pre-recorded. Live classes are there for you to actually get the feel of being in a class, discuss with the teachers and interact with them and ask your doubts. There is the express exam module, which is there. So that is in order to help you revise just before the exam, just the important points and important questions. Then one-to-one doubt clearing sessions are there, and hard copy notes are there. Question bank is there of various difficulties, which is important not only for your exams, but in the future for NEET PG, FMG, and all. So these are the various subscription plans which are there, and you can use my code Dr. Shakthinag 20 for discount on subscription. So thank you for watching. If you got any queries, then you need to contact Team Auricle. These are the various social media handles that you need to follow. So thank you.